All right, everyone. Welcome here to our community discussion on opioid recovery. And we've changed the format a little bit to roll with the crowd that we have here, and that's good that we can do that. I think we all learned that in politics and in recovery and in law enforcement and in all of the providers, vendors, and stakeholders that we have in the opioid recovery community, or opioid battling community. And as we all know, this is an issue that runs in just about every family that we know, in one capacity or another. You could be living in Clinton, Massachusetts, you can be living in Wellesley, Massachusetts, you can be living on Beacon Hill, you could be living on Martha's Vineyard. It knows no distinction for class, age, race, gender, or financial status, and it's affected our community dramatically. We did have a pretty interesting program that we were going to run using a series of vignettes and asking each of these individuals to respond to how their office, their recovery center would respond. But with the kind of the change in the situation this evening, we've decided to help each of these people get to know each other and what resources they offer. So let's start on the far right, and if you could tell us your name and what you do and what your group sees as their part of the stakeholder share of this situation.
My name is Tanya Murphy, and I am the Vice President of the NAMI group for Central Massachusetts, and we meet once a month and try to get the word out to the public about mental illness and how it affects families. And we also meet with families dealing with mental illness in their homes. And we basically have a support group that meets every other Friday as well. And we try to get out to the hospitals, the police stations, local authorities, to make them aware of mental illness, because what happens too with people with mental illness is they'll turn to self-medicate with drugs and alcohol instead of taking the medication for mental illness. So we do see a lot of that happen. And we also try to make the families who come to us for help on like Fridays, we just have a support group, we all talk, and we try to get them the help they need as well, and give them information on where to go and where to find help for themselves and their loved ones.
And do you work with any other organizations to try to be supportive of the people that you service?
I'm new to the board, so I don't know. I guess, Jean, you would have to answer that question. I don't know.
I don't think we do, but we certainly would be open to doing that.
Definitely.
As much as we could.
We're trying to do a refresh and get connected with other groups so that we can, because it all kind of is the same. You know, it starts somewhere. You know, the mental illness, then the drug abuse, and if we can work with people who are dealing with the drug abuse and the self-medication, then maybe we grow together and get stronger together.
Because it seems like that's what we're seeing, that this is such a multi-layered, like peeling an onion back, a multi-layered issue affecting so many people. You know, in my own world, where veterans, I'm a veteran of Iraq and Afghanistan. Many of my colleagues have come back and have experienced horrific things, and it leads them into issues that may or may not be being adequately dealt with by the VA or local veteran services. And it is. I do see that. I think it's like a layered approach where you need potentially help from all different organizations here. Maybe you could pass the microphone to the chief, and if Chief, you could tell us a little bit about the efforts of your department. We thank you. Well, the last one we had, you sent up, I believe it was Lieutenant Coyne. He did a great job when we were here the last time. And if you could tell us the efforts of the Clinton Police Department, and I know your officers are out there all the time saving lives left and right using Narcan and various other things.
Yes, I'm Chief Lovinger from the Clinton Police Department. I've been on the force 40 years, and a great deal of our time is spent dealing with this problem right here, and mental health. Those are our two big issues. And we're taking different approaches. Over the years, we evolved on how we handle the issues. We've always been on the enforcement side, and that keeps us very busy. We have Northwest County Drug Task Force that tries to attack the people that are distributing it. We try to target people that we know are selling stuff that's creating the overdoses. We could, our intelligence is that good now that we know when someone sells some stuff from an overdose, where it came from, and then we try to go after that person. We are using Narcan. I think we used it between EMS and the police officers 40 times last year, and now people can get it on their own, and so we're saving a lot of lives by carrying the Narcan. And people got to remember, when you use that Narcan, you have to go to the hospital afterwards, because the effects of the Narcan can wear off before the effects of the drugs. Everyone thinks that they're getting heroin now when they're going out with the street dealers. Virtually all of it is fentanyl now, all of it. We just did a raid last week. We got a couple individuals from Providence, and they had 2 softball-size packets of what we thought was going to be heroin, but it all tested out, all of it fentanyl. And he was driving a nice BMW that the chief would look good in, and so we'll seize that. But as far as the different programs, after we have an overdose now, I've got an order out that we're going to approach the people that have overdosed, because they're very susceptible to receiving help right after they've had not hours after, but within the first 24, 48 hours, they're more likely to go for help then. So the officers are going to approach the person and try to get them into a place to get some help. I'm talking with the other member communities of the Northwest County Drug Task Force to see if we can get together, to get a team together, and possibly get a social worker, an expert in the field to help us. So when we go to these houses, after we've been there and we've used Narcan and they've gone to the hospital and they've gone home, to try to convince that person that, hey, you nearly died, it's time to go get help. And we're trying to get that set up now. We're involved in a program, a statewide program I signed on, that every officer is going to be trained and recognizing mental illness, and every officer has to be receive that training to deal with it, because they go hand in hand. Once someone's been using drugs for so long, they develop a lot of mental problems that go along with this. So we're very busy, like I said. Probably between the drugs and the mental illness, it takes up an awful lot of our time. And if we could do something to stop that, it'd be good. As far as prevention, the DARE program's gone. I don't think enough of time is put into prevention. I think that's the key. Kids are still getting involved with it, and the studies have shown that the longer you can delay the use of alcohol and marijuana and drugs, the less likely that they'll develop a substance use disorder as an adult. And it's astronomical. It goes like this. If someone starts using drugs at 15, or smoking pot or using alcohol at 15, they'll have like a 48% chance of having a substance use disorder as an adult. But if you can delay that to 21 before they start having their first drink or smoking marijuana, it's like an 8% chance that they'll develop it. So delaying the use of substances is very, very important. And these are the things that we got to work on. I think if a child comes home and he's been out drinking at age 15 or out smoking pot, you got to treat it as a big deal. You got to delay it as long as possible. I think that's where we should be focusing a lot of our preventive efforts. And with that, I'll stop talking. There you go.
Doctor, before you start, I want to introduce, we have my colleague, Representative Denise Garlick, Chair of the Committee on Mental Health and Substance Abuse, who is really a leader in the Commonwealth at this. And yeah, I would ask that she give some of her remarks. She is the one who came up. She and her staff are the ones who came up with the program that we were going to do tonight. But I think her presence here is really going to raise us up and tell us some of the resources that we've provided for on the state level legislatively and how we're attacking this problem from the House. So, Representative, what we did was we started, a couple of our providers from NAMI and Chief Levenger from the Clinton Police Department have already told us what they provide, and we're kind of using this as a get-to-know you among all of the different stakeholders and resource providers here in central Massachusetts. So your presence is wonderful. Thank you so much. And Andrew, can you hear us? Is everything all well? Very good.
So I wanted to say thank you. Is this mic for the audience as well, Andrew? So I wanted to say thank you for the people who are gathered here and for the people who are on the stage, which Rev Naughton informs me are the people that are doing the heavy lifting out here in the county and in these communities. I want to recognize that our colleague, Rep. Danielle Gregoire, is here. And I would like to take this moment to talk about Rep. Hank Naughton and the voice of this county, the number of deaths that you have suffered since 2013, the work that you are doing. He always reflects that voice at the State House. I'm the chair of the Joint Committee on Mental Health, Substance Use, and Recovery, and it was very, very important to me to come here this evening. And it is more important to me now than ever, because my understanding is for all of you that are working and working so hard, tonight is actually a night for you to understand each other's work a little bit more. And that was the idea behind the entire program. So I'm really pleased the way that this has actually come together. The idea around the program, around community conversations related to the work that we're doing on substance use and recovery is in the State House now, because of voices like Hank's and because of voices like Danielle Gregoire's, is that we know we have tremendous strength in our communities, but we know that we don't have enough synergy in that work. So you're doing work and it may feel like you're doing that work alone or that your work isn't being noticed. Why that matters is because for families and for individuals, because of stigma, they don't want to talk about the issue of substance use and recovery. They don't want to believe that this could impact them. But the fact is that we know that it impacts almost everyone in the Commonwealth in some degree. But because they don't take it on head first, the time where they're looking for their resources and their help is when they're in crisis. And what we're trying to do, and what Rep. Naughton is trying to lead here in the community, is that you have the right information at the right time, that you know these folks and that you all know each other, and we can plug into that kind of synergy. The opioid bill that Rep. Naughton voted on and helped to inform as it was being developed has three major parts. But the first part, and this is the House of Representatives that has done this, it was not in any original legislation we got from anybody else, but the House added the entire first part of the bill, which is around community prevention. We hear a lot of work, and I'm sure that there are representatives here from the schools, and we talk a lot about our children, and we talk a lot about substance use prevention and mental health in our schools. because in so many ways our children compel us to do this work. But we have to face the fact that our children are in school for 6.5 hours a day. They are in our communities 24 hours a day, 365 days of the year. And while our teachers and some of the administrative folks in the schools are doing great work around screening and doing, being prepared to help individuals, for our children, we might find that the most important person in their life is the coach, the volunteer coach. It might be the lady who works in the cafeteria who actually sees them and interacts with them every single day. So we know that those folks, it might be the religious leader in the community, it might be the person who checks them into the YMCA. So we know to really make this work, we need to be out in the community. So the bill calls for a community prevention plan commission, and it's based on best practices. We already have the model that came out of the Promote Prevent model that we had, and so we established a permanent commission, and you will all be glad to know that are doing this incredible work, that there is money attached to this, and there is a trust fund. And in fact, we've seen the supplemental budget that Rep. Norton and Rep. Gar and I all supported just this week. It's $7.5 million has been directed to this community prevention model to strengthen the work that you're doing. The second part of the bill, and we can talk about this if Rep. Norton wants to explore this a little bit more, is around expanding the behavioral health network. I know for as hard as people are working here and as concerned as community members are, what actually happens is you are in crisis, you do finally know who you should call, but you can't get the services you need. You can't get the acute care services you need, you can't get the continuing services care that you want, you can't get the transitional services in between. We want to strengthen that whole network. And in this bill, because of the advocacy of the representatives, we also say that if you want to build something in Massachusetts, if you want to call yourself a recovery center, if you want to say you're going to do that work, well, it has to meet the Commonwealth's needs. And what we're trying to stop is the entities that are coming into our Commonwealth dealing with the people that we love that are here just for profit. And so we strengthen the licensing of the Department of Public Health. We strengthen the way we're going to allow determination of need, what actually is going to be here. And then the final piece that I know you're also involved in is around the care and treatment. We are compelling emergency rooms to give medication-assisted treatment in the emergency room, in that moment of crisis. So what does that mean? It means something like probably Suboxone. Medication-assisted treatment right now is methadone, Suboxone, or Vivitrol. In the emergency room, it would be Suboxone. Why would we do that? Because people who are in crisis, who have overdosed, we know, I'm a nurse by profession, we know in that emergency room that they are, at that time of detox, particularly if they've been detoxed with Narcan, every cell of their body is begging for a drug, and they cannot, and it is not fair to ask them to make the best decision for themselves moving forward. But if we can give them some medication-assisted treatment, if we can smooth that suffering, and we do a real handoff, not we're giving you this so you can get out of the emergency room. We're giving you this, and we have an appointment in the community support group for you tomorrow morning at 9 a.m. And we contacted Heather, and Heather said she's going to pick you up and she's going to get you there. We can get people to the services that they need. We have, the Commonwealth has now written you a prescription for Narcan. Right now, any person in this Commonwealth can get out of your chairs right now, go to your local pharmacy, and pick up Narcan. You can pay for it with your insurance, or you can pay for it with cash, but you can get it right now. And we have now made every single person in this Commonwealth a lifesaver. Really important. For our Minnesota folks, Chief, we have in this bill about the purchasing of Narcan. We're asking our first responders to do a tremendous amount of work and put out a tremendous amount of resources. We want to support that to the best of our ability. And then for folks who have someone that they love, who is on a long road, and we know that the road to recovery is long, and we know there's a lot of bumps in it, and many people are on mass health, and they were being refused in their own community services because those services wouldn't cover mass health. This bill says that anyone providing services has to accept Mass Health. So there's more things we can talk about. I'm sure Rep. Norton has some things that he would like to share in Reprobate but this is a good, strong bill. First on prevention, second on strengthening the system, and third on care and treatment. But it's really only as good as the people on this stage. We are doing at the state level the best we can to support you. You need to teach us more that we need to do, and we will move forward. And before I hand back the mic, and excuse me for the length of that presentation, I do want to say, with the leadership of people that come into our offices and speak to us, the bill also has a recovery coach mission. This is very, very important. Recovery coaches may well be our way to help this population the most. And in my heart, I believe that recovery coaches with good education that we can certify, that we can then pay for with insurance, will save 2 lives. They will save the life of the person in crisis because they have the lived experience and they know what it takes. And more than that, they will save their own life. Because what we know as a person in recovery needs 2 things especially. I tell you, as a mom, they need love. And I tell you, as a nurse, they need hope. But what we do know is the research tells us they need housing and they need a job. And to be a recovery coach will help a long way on that pathway. So thank you, Rep. Norton. And I just want to thank you for all of your input, all of your support. Your community is so well served, Rep. Norton, by your leadership, because the voice of this community that is struggling is heard so clearly, and I respect you so greatly.
Thank you. The chair lady called me, obviously isn't used to our congestion as you get further west. Called me, said she was stuck on the pike, and she said, "Oh, I thought I'd be there in plenty of time. I left at 4:40. I said, "I would have told you to leave at 1:40. The way it's been lately, no, you don't know. It's been crazy. We have the pleasure of having Dr. Kavita Babu with us, and I'll let the doctor tell you about herself, but primarily for this evening, and I was having a fascinating conversation with her outside. She's the Chief Opioid Officer for the University of Massachusetts medical system. And the fact that they've been forward-thinking enough to actually appoint the Chief Opioid Officer says a lot about them and a lot about the person that they appoint. Doctor.
Thank you for having me, and I'm so delighted to be part of this conversation with progressive policing and the legislative efforts to really combat the opioid crisis. And so I just want to quickly say that I'm joined here today by Scott Pelletier, who's one of our health coaches, by, oh, I'm sorry.
I think they're working on the mics, but I think I'll have to ask everybody to speak up. The mics are primarily.
No problem.
You're doing a great job, Andrew. Let's hear it for Andrew.
So,
The acoustics have always been tough in here, so I'll ask everyone to speak up.
and please tell me if this is too loud then for the. Well, I'm Kavita Babu. I'm the Chief Opioid Officer at UMass. I'm joined here by Scott Pelletier, who's one of our health coaches in the emergency departments at University and Memorial, by Brittany Chapman, who's our research coordinator and a primary member of the Overdose Prevention Fund, and by Jackie Zhao, who's the project manager and sort of the lead point for managing the opioid crisis task force here in Clinton. And so I'm very grateful to have our colleagues here tonight. I am an emergency physician. I've been practicing emergency doc for 18 years. I'm the chief of medical toxicology at UMass. And from a public health perspective, there has really been no greater public health crisis than the opioid epidemic. And so a few months ago, I approached Eric Dixon and sort of as was previously mentioned in terms of synergy, we have a huge healthcare system with so many innovative and forward-thinking clinicians that one of the things that's been really challenging is just aligning all of those efforts. And so I met with Dr. Dixon, the CEO of the UMass healthcare system, who is also a practicing emergency physician, and said, I really think that we need sort of top-down alignment of our efforts. And he said, are you volunteering? And so I got the job. But I think that what I see right now in sort of following nominations and following the Clinton PD, and in terms of the legislation, is really that there is this opportunity for us to bring progressive and evidence-based healthcare to our patients, specifically around opioids, and that requires everything from improved opioid prescribing to disposal of unused opioids in our communities, to improving access to treatment, and then ultimately decreasing stigma, as previously mentioned. And so we're looking to align our efforts on all of those, and I think that it's been really interesting to see how progressive and forward-thinking many of our communities have been. This is not just an urban effort in Massachusetts, but we're following the lead in so many ways of what we're seeing. Clinton, at Health Alliance, Marlboro, really our community providers have done just an outstanding job of trying to bring the best treatments to our patients. With regard to that, it is very interesting to see how the evolution of care has changed in the emergency department setting, and the new legislation is, I think, going to create some harmonization of efforts among all of the emergency departments, particularly with respect to Suboxone. As an emergency provider and a Suboxone waiver physician, what I will say is that it is often hard for us to get patients to accept medications for opioid use disorder. And this idea of sort of drug-free recovery penetrates our parents, our patient population, our communities, to the point that when the offer is made for medications for opioid use disorders, we often will find that patients decline. And I think that to whatever extent that we together as a community can support this idea that the evidence for mortality benefit for recovery falls out on the side of medications for opioid use disorders, we're doing a service to our patients and to our communities. I'm also here on behalf of the Overdose Prevention Fund, and so we have a clinical education and research fund at the University of Massachusetts that supports some of these forward-thinking efforts. And so just yesterday, we put a medication disposal box right down the hall from our surgical clinic, because our surgeons came to us and said that they have so many patients that are returning with unused opioids, which is a major source of first exposure for adolescents and young adults, that we're able to sort of proactively say to our patients, when you have unused opioids and you return for your first post-operative visit, we have a place. And so I think that those kinds of innovative programs, the energy and collegiality of the providers across specialties who are working in this area, those are going to be some of the solutions that we try to implement as rapidly as possible on behalf of our patients. Thank you again for your time, and we'll be around afterwards if you have any questions specifically.
Gotcha, thank you. Well, Noelle, we don't need to be that formal. People can introduce themselves, but Noelle Jordan, who's a licensed clinical social worker with training for recovery in Lunenburg, and BS in psychology from Northeastern, and her master's from the University of Chicago, with all the liberals out there. It's all right. It's all right. It's some of us here. Anyways, Noelle, I'll let you describe what you've been doing in your work and how important it is for you to be here. Thank you.
Anyway.
Well, the
evening,
good thing is
everybody.
this is going to go back out over social media and local TV, so he's getting that.
Okay.
So that's serving that purpose.
Welcome to everyone. I want to say first, I'm honored to be on the stage with everyone here. Honored to have been invited. I am a clinician that works in the community, just an LICSW, chronic therapy, doing all kinds of stuff, couples, groups, kids, teenagers, adults. I have insurance rates, and I have a very affordable sliding scale rate. My husband quit as my business manager because my rates are so affordable. And one of the reasons is because I worked at McLean Hospital for about 6 years, and they have a lot of very expensive programs, world-renowned. The research there is fabulous. They do great work. But one of the patients said to me, I don't know how anybody gets well. I have money for yoga. I can pay for mindfulness. I can pay for my meds. I have a stable place to live. So I don't know how everybody does it. So that was one of the things I took. And help that plan to success. And that's really what I like to focus on. And I also do kind of unconventional work with my patients who have substance use disorders. I go to doctor's appointments with them. I do family visits and work with the families so everyone's educated on what's going on, what they're seeing, and what the plan means. I've worked with a few adolescents that have some serious mental health challenges. We do exercise, we run around the track, we go for walks, we walk animals during therapy. I just walked around with a 5-week-old baby in my office the other day. I encourage patients to bring their children so they don't miss. So again, it's really trying to take a really comprehensive, kind of unique, integrated approach to care. And it really does work very well. And I think everyone on the stage also represents that integrated approach from the police, from a mental health perspective, medical services throughout the community, and the legislation. It really does have to apply. If anyone has any questions about care, what they should look for, questions they ask before they see a provider, I'm here. I'll certainly be open to answering anything. And that's who I am and what I do.
Well, that's great. Thank you for being here. I'm sure your presence is going to be a great addition and helpful to all of our other. Are these working now?
Yep.
Oh, how do you like that?
I think you need to hold the mic close to your mouth and then it leaves.
Hold it close to your mouth?
Hold it fairly close.
Fairly close. Okay. Well, I just want to introduce Brian Jenny, who is from the Commonwealth of Massachusetts Bureau of Substance Abuse and Addiction Services, but he's the Director of Youth and Young Adult Services, which I think is incredibly important, especially given the venue that we're in tonight. And Brian, please take it away.
Is this on? Is this pretty good?
Try this one.
How we doing? Good? Better? All right, it's a beautiful thing. All right, so my name is Brian Jenner. I'm with the Massachusetts Department of Public Health, Bureau of Substance Addiction Services. Specifically, my office is with the Office of Youth and Young Adult Services. So we are basically overseeing services and programs for children ages 8 all the way up to age 25. So we're doing intervention services, treatment services, and then certainly recovery support as well. The Bureau of Substance Addiction Services does a whole lot. The mundane is the regulatory oversight of all of our providers across the Commonwealth. The exciting piece is that we get to work with the legislature around some of the money, and we kind of look for evidence-based programs that are out there. We solicit providers to kind of submit proposals to operate those and fund those programs. So we're kind of the government oversight of those programs. So these guys advocate for the money, and then we're kind of the stewards of that money to make sure that it's being spent effectively. I would be remiss not to mention a couple of resources that are out there. There is the helpline, which is really the resource that is available for folks across the Commonwealth. If you have a loved one in need, mass or helplinema.org is the resource to go to. It is a website. They also have a phone number as well, and they will get you into, they'll kind of educate you about the treatment services that are available, and you can actually see all the services across the Commonwealth, from outpatient therapy to medication-assisted treatment to detox and stabilization to residential treatment. So helplinema.org is a very valuable resource. The other piece that we're always looking for is family support, and there are two organizations that my office oversees. One is Learn to Cope, which is a phenomenal resource for parents with a loved one that is suffering from an addiction. That's a tremendous resource for a number of reasons. It's just a support network of parents who are going through the same issues. And the other is Allies in Recovery, which is actually a web-based platform that kind of goes through the CRAFT model. And it's for those that don't want to step into a group, it kind of gives them that anonymity to kind of seek out the services kind of in a private forum. But again, specific to my office, everything from intervention services to treatment to recovery, it's kind of soup to nuts, 8 to 25. So happy to speak to anybody about that particular age group privately at the end of this forum.
That's fantastic. I think that's that might be the only one working on this end at least. Our office has done great work over the years with Spectrum, who are based here in central Massachusetts, but have really grown tremendously all around the country. And Dave Tifusi has taken a lead in that, and he's kind enough to be here on behalf of his organization tonight. David, thank you for being here.
Thank you. I think as noted, Spectrum actually is going to be celebrating actually their 50th anniversary as a substance abuse provider in Massachusetts. So we're not new to this, although I think that we're still learning and growing as well. I think one of the things that we have done over the past several years is to make sure that we really offer a full continuum of services. In addition, what we've tried to do, because I think you brought up a really good point regarding insurance, is we're now insurance blind. One of the first things that I did when I joined the organization was to make sure that every payer is now contracted, both on the public sector side as well as the commercial side. And I think that's a very important part for those people in the clinical community as well as patients, and not having to worry about, will my insurance company take this provider? That's not an issue, which I think is a very important component. In addition, I think one of the things that I enjoyed, and to be completely transparent, I actually worked on the opposite side of the house, the ones that I'm sure a lot of people didn't like, which was the insurance side, for the previous 27 years. And one of the things that I had noted as always being a big issue, which is something that attracted me to Spectrum, because they don't do this, is that they, as they're having a full continuum of services, are a big believer in the patient being admitted to the most appropriate level of care where they can be directly admitted. There are a number of programs throughout the state, both on the mental health side and the substance abuse side, where they only will take a patient as a step down, not as a direct admit. And our belief is if a patient needs a residential or can be treated by medication-assisted treatment on an outpatient basis, and that's the most appropriate level of care, they should start at that level. And I think that's something that's really good about Spectrum. In addition to having the full continuum of a detox, a residential, ATS, a CSS on the public sector side, they also offer an IOP, as I said, outpatient with medication-assisted treatment, where we have actually 13 locations. So as you noted, we actually have locations throughout the state. So actually in the Clinton area, you have some options. You go to Worcester, you can go to Southbridge, you go to Millbury or Leominster, all of those really within your area. And what we do, which I think is very unique, which I think is great for the community, we do what is known as same day. So basically a person can come to us. They do not need to get the call in. They can just come to us that day and get treated, get induced, and get treated for the appropriate medication-assisted treatment. Although I do need to highlight, which is something I hope that as the commission looks further at, is that I know that Suboxone is the primary medication, and I believe it's Suboxone, but for those patients who may require a little bit more supports and more structure, methadone might be also thought of as a good alternative. So I think that, although I think that we're going in the right track, we're going down the path, I think that really, as you noted, there's 3 forms of it, and I think really making all 3 forms readily available might be something that one might want to relook at as well. In addition, we also offer 3 peer support programs, and again, I think something unique to Spectrum is that those programs are free of insurance. A person can go to any of our peer support programs, which are in Marlborough, Lawrence, and Worcester. They do not need to have any insurance, nor do they need to be in a Spectrum program. And I think that one thing that we can all acknowledge from this terrible illness is that sometimes the biggest issue for patients is having too much time. And I think that in addition to getting counseling and medication-assisted treatment, having the ability to actually talk with peers, and I think we can all kind of acknowledge through the peer support program that a lot of times patients may be able to identify more easily with a peer than with a clinician. It doesn't replace them, it would be in conjunction with a clinician. But again, it'd be another major support for them. And to go one step further, I think in looking and trying to be creative as an organization, we're looking at every tool, and we're going to, beginning in 2019, taking a new app we're going to be utilizing. Yes, everybody has a smartphone, and one of the issues that I know, again, coming from the insurance companies, which I used to always know on the opposite side, was when patients were discharged from a facility, one of the biggest concerns always was, well what's happening? Why are there such high recidivism? And for anybody that doesn't know, roughly 60% of every substance abuse client is likely to fail at least once, sometimes several. So what we're going to start to take a look at is a tool where a patient, when they come in, will have them sign a release of information and basically put a simple app on their phone. And that app basically will ask them, after they've been discharged, how are you doing? And they'll have a simple option. There'll be a green smiley face, a yellow kind of line, and a red frown. And if we get a red frown, our organization, our aftercare specialists, will be held accountable to actually contact that patient to see what they can do to maybe provide them additional services so they don't show back up at the ER unnecessarily, or God forbid, even worse, are successful in overdosing. So I think, again, I think what Spectrum's doing, I think there's a lot of other organizations looking at that as well, is really looking at every tool that's really available to them. I think that, again, when I worked for the national payer that I worked for, having the ability to actually see what we have in Massachusetts, I don't think people realize how fortunate we are here, that there is not stigma. You go to a lot of other places in this country where you're shamed and you don't want to admit you have an illness. And I think that it's in Massachusetts, we identified it as an illness, and I think we're actually taking appropriate steps and bringing appropriate treatment to meet those needs. So thank you again for letting me be here today.
Thank you, David. We're lucky in a way in Massachusetts that the system that we've designed and are continuing to amend has provided for not just our public institutions of medical care to provide services, but for numerous private institutions to do that as well. Just today, just before I left the office, I did read that a bill was signed today at the White House to deal with the opioid issue, the opioid epidemic. Don't know what's really in it yet, haven't drilled down, but one thing that stuck out to me was that it passed the Senate by 98-1 and passed the House by 393-8. So you're not seeing a lot of that these days, of bipartisan work like that in Congress. So that tells us a lot. But one of the elements of the bill are public-private partnerships with many different private entities, such as Amazon, Blue Cross Blue Shield, Cigna, CVS Health, Johnson & Johnson, the Ultimate Fighting Championships, who are probably buttering their own bread there, National Head Start Association, many others. And so here in Massachusetts, we are lucky to have numerous, like Spectrum, private providers in this industry and in this space, and one of those is also the Recovery Centers of America, and we're happy to have Tara Rivera from that group to talk to us about that organization and all the help that they can provide.
Thank you. Again, thanks for having me. It's an honor and a privilege to be here. I do work at Recovery Centers of America in Westminster. We have another site in Danvers. We are an inpatient detox and residential facility. I also like to disclose when speaking that I'm a person in long-term recovery, as well as a recovery coach. So I get this from a personal level as well as a professional level, and it's an honor and a privilege to serve people in my community that struggle with addiction, as well as their family members, and support them. I'm a huge advocate of Learn to Cope and Allies in Recovery. Those are two of the main resources that I give to family members that I talk to, and I have those conversations on a daily basis. I have moms and dads and husbands and wives calling me on a day-to-day basis that are in crisis, that are looking for resources, that are looking for help, trying to figure out, where's the best place to go, what's the best next step to take. So I'm honored to be able to help in that situation, in those crisis moments, with family members and people who struggle with addiction themselves. So at Recovery Centers of America, one of the great things that I get to do is education. So I'm really passionate about educating people about the disease of addiction and helping to break that stigma. So we have developed a first responders program. So I was able to, and I continue to, we have OEMS credits for it, so they can, get OEMS credits for attending. And it's a training on addiction, and we teach them that it's a disease, it's not a moral failing. And we also talk about compassion fatigue, because we know our first responders are out there and they're Narcaning sometimes the same person on a repeated basis. So I kind of talk about those things, and I talk about them as a person in recovery, so people understand that, when you've Narcan that same person 5 times, that in 5 more years, that person could be me and sitting right next to you and a valuable member of society and contributing member of society. So it's pretty powerful when I get to do that, and I absolutely love to do that. I also do work with human resources and different large organizations, smaller organizations, to teach them about their workforce and how to kind of prevent those things or have those conversations or look for the signs and the symptoms in that kind of arena. I think the misnomer is that if someone has a job, they must not be struggling with addiction, but that's not true, right? So we struggle with addiction, and there's lots of high-functioning, people that are struggling. So we kind of talk about that. So that's something fun that I get to do, in not just placing people in treatment, but just being part of our community. The Recovery Centers of America hosts the Joint Coalition monthly, so we do a lot of grassroots work in the community. And one of the things I do as well in terms of being a treatment advocate, if I take obviously every single phone call that comes to me, nights, weekends, doesn't matter. I tell people, please don't ever feel like you're inconveniencing me. I want those phone calls. So unless I'm sleeping, I will answer your phone call. And if I'm sleeping, I will promise to call you back first thing in the morning. If I can't place the person at Recovery Centers of America based on their insurance accepted, I do a bed search and I place that patient somewhere. So I have great connections with Spectrum and other providers in the area. So I make those connections and those phone calls so that the family members don't have to struggle doing that. They're in crisis, and to have to call this place and that place and think about what insurance, and do I need ATS or do I need CSS, or, I say, let me handle it. I make the phone calls, I do all the footwork, and then call back and say, okay, I have you a bed at such and such a place. This is the phone number, please call. And then, follow up with me, if there's any issues or concerns, or let me know that the person made it successfully. So I do a lot of that. I work with a lot of the drug courts, Worcester Drug Court, Fitchburg starting a new drug court. We're really excited about that. So we're a big supporter of the drug court programs, the Office for Community Corrections programs, the diversion programs. So we focus a lot on that. We lend a lot of support and education to that community as well. So pretty much anything and everything that I can be part of, in the community to educate people and just to have a presence, we take advantage of doing that because we really want to be seen as a community partner. So grateful to be here and be part of the conversation.
Thank you very much. And speaking of the courts, and again, our public servants that we have here with us, like the chief, and we're very lucky in this area of the Commonwealth to have some very committed public servants and those that work in public safety. We've got Steve Mendoza from the Juvenile Court Probation Department here with us this evening. And I'm not just saying that because he's my high school classmate. Not in this high school, though. It was the other high school. But we're lucky here in Clinton and in this area to have a great chief of our probation department at the Clinton District Court, who's very quiet, unassuming. He's mad at me that I made him get up here on the stage tonight, but does a lot of good for a lot of people, and you'd never hear it out of him. But I know he's had a dramatic effect on many people's lives in this community. He's not just in it to punish people and to hold them accountable. Yes, hold them accountable, but help them get back on track. So I think we've got a great resource in this town, and our Chief Probation Officer at the Clinton District Court, Pat Ball.
Thank you, Representative Naughton. Thank you so much for inviting me here tonight. Again, I wasn't expecting to be a panelist, but I do appreciate you caring so much about your community to hold something like this. I'd also like to thank Chief Levinger and the fire chief all throughout our district, the nurses and the doctors at the emergency rooms, because you people on the front line, we appreciate the work you do. The only thing I'd like to say is that we really need beds, detox beds. We need psychiatrist, so someone can get a mental health appointment. Those two things are really important to us. Probation, we want people to know that we want people to have a healthy, happy, successful life. That's our goal. And I want people to know out there that you're not alone going through it, that so many people are going through this. A lot of families are going through this. Nobody escapes it. We're all involved in it. So please come forward if you have a loved one that needs help. Don't sit back. And with that, I'm just going to pass it back to you.
Thank you, Pat. And going all the way back to the other side, Jared from Moore. Jared, if you could tell us about your organization, and we really appreciate you being here tonight.
Absolutely. I will keep it very brief. My name is Jared Owen. I am a man in recovery, and for me that means I haven't used alcohol or any other drugs in over 5 years. And I'd love to tell my recovery story to anyone after this presentation, because our stories have a lot of power, and that's what's breaking down stigma and driving this movement. So I want to thank Rep. Garlick, Rep. Naughton. We're really lucky in Massachusetts for a lot of reasons in regards to addiction. One of them is that we have legislators that really understand the issue. And I've had the privilege of meeting with Rep. Garlick several times over the past year. Rep. Naughton, I look forward to getting to know you. And I was with your co-chairwoman today, Cindy Friedman, and we have excellent representatives that are listening to the recovery community and people with addictions to make a difference. I think we're going to be a model for the nation. So I work for MORE, the Massachusetts Organization for Addiction Recovery. Our mission is to organize recovering individuals, families, and friends into a collective voice to educate the public about the value of recovery. What does that mean? We educate and we advocate. So raise your hand if you've heard of the Good Samaritan law related to addiction. So this law protects people that call 911 in the case of an overdose from being arrested for simple drug possession. My boss helped to write that, get that passed, and then worked with the AG's office to publicize it. We do education for people early in recovery at some of the peer centers that were mentioned to help them get over those really difficult roadblocks like employment, housing, etc. We also have recovery coaches on staff that work more on a one-to-one basis. We do education for agencies. This is my second trip to beautiful Clinton this week because I was at the probation training center last week. And talking to probation officers, we talk to DCF workers, we try to get out there in the community and really educate. The advocacy side is where we take all that information we get in the community, we try to take it to policymakers and make a difference so that more people can get into recovery and more people can stay in recovery. So very briefly, a couple of things that have been great this year were the opioid bill, which we did a big survey and we're proud to be named on 4 of the commissions that are in that bill. So for prevention, for access to medication-assisted treatment, for Section 35, which is involuntary treatment, and recovery coach is the most important one. So we're working to funnel information from people to those commissions, especially people in recovery and providers that are part of the community. So as part of my journey, I spent 18 months incarcerated, and I was really lucky that I had resources and a good lawyer, and I got released to treatment that saved my life. A lot of my brothers and sisters with this disease are not that lucky, and they're serving long sentences or they're getting released without follow-up, and right now that's tantamount to a death sentence. So we worked really hard on criminal justice reform this year, and we're happy to get a bill passed that had measures for diversion so that people with low-level offenses can get sent to treatment rather than jail. Also lessen some of the collateral consequences like the fees for probation and parole that keep people down, and lower CORI sealing time so people can seal those criminal records sooner and have that hope. And finally, we're very happy we have Rep. Garlick's predecessor, Rep. Malia, who's a woman in recovery now, working in the Ways and Means Committee. So we got some excellent budget items, including funding for 5 new recovery centers that are going to be coming up across the state in the next year, as well as funding for beds in the diversion programs. And I just want to mention that hopefully these beds are coming down the line because Mass Health, through a complicated process, is now paying for the clinical services for people while they're in treatment, and that means federal dollars coming into our state to expand this system. I just want to make you aware of a couple of resources I brought. Our most popular is our resource guide, which has list of all the treatment providers with their phone numbers, so you can call directly. I also recommend the BSAS helpline is an excellent resource for this, and they've done a great job with that, and we love working with the department. I also have a language guide that I wrote. The language we use to talk about addiction is incredibly important because it changes the way we think about addiction and even changes the way providers treat people with addictions. So we also do a workshop on this that we were proud to do at the NAMI conference last weekend. So check that out. And finally, our newsletter has details about all these great policy issues. I encourage you to go to our website, join more, get involved, advocate for recovery. Recovery is possible for anyone, and there's hope out there. Thank you.
Don't you love when a guy's passionate about what he does? That's great. And thank you for sharing. And, you know, we have, as I said, we had the vignettes. That was kind of the program we had put together. But, and we do have some questions stemming from that, and I have a couple of questions. But really what my goal here, when we did our change-up, was for you guys to kind of hear each other and get to know each other. So before I go out to the audience or even ask some questions myself, let me do this. Do any of you have any questions for each other? To extrapolate on the resources that you have, how you could work together?
Also just mention, I know that you had noted that you're looking to get people to potentially accompany you as you guys go out after a overdose. I don't know if you've looked at, I know one of the things.
I don't even know if it's working much, but at least it looks good.
Yeah, one of the things that we had noted at Spectrum, we had the ability to be part of another kind of organization that was doing similar things that I think you were looking at. The Plymouth Outreach Committee, there's a police officer, Alan, has already kind of created what you're trying. I'm assuming you're trying to maybe mirror that program in some sense?
Exactly, yeah.
Right. It's been really effective.
North County, they do it countywide.
Correct.
And we would like to do that. I'd like to do it at least.
Won't you expand on that?
Yeah, so what happens is when a person overdoses, what they've done is the next day, a police officer goes out with, could be an outreach coordinator of some sort, somebody who has a skill set in the substance abuse field, will accompany them and try to, as they noted, discuss various options they might have to get into treatment or to find alternatives way to treat themselves. And I think that's really a good way to do it. In addition, what they've done, which I think is a really good tool, and it's only unfortunate at the county level, but I think we should look at it more statewide, is that if a person happens to overdose and say they're overdosed in Worcester, and yet, you know, they get the similar situation happens in Clinton, they'll be able to have that information available to them. It's not like a PHI violation, so then we can know, oh, by the way, this person's already had this issue, how they're dealing with it, which I think is a really important component. We want to make sure we're providing resources, doing it in a way that's thoughtful, but also making sure that we can really identify if another person may have gone through something similar in the past.
What are you saying, Harold? If someone from Clinton went out to Worcester and overdosed in
Right.
Worcester would contact us, and then we would make the contact there. They're experiencing 100% of the people are letting them in the door to talk to them. And
It's an amazing number.
It's a huge number
Right.
that have actually gone to treatment. If you hit them within that vulnerable period after they have the traumatic experience of an overdose, they're thinking after that. I think it's like about 70% actually are going into the.
Yeah, one of the big things, again, I'm talking about funding though, which I think has made a big difference, is that they were able to get grants that have been able to come in. So again, if there's funding, clearly there's a perfect demonstration where you can show there's a success. I mean, everybody's looking for return on investment. What a return on investment where you're getting 100% of people going into treatment. So.
Is that, Chief?
We're doing that now. I have an officer that does that now, but it's just Clinton. We're not getting the communication from other departments. And
Is that something, Chief, that as legislators we could be helpful with to try to design something to formalize it? Sometimes when you formalize a program,
the North Worcester County Chief, we have a drug task force for enforcement purposes.
Right.
But this, I'm trying to get the same group together to do because the problem, we have the same players.
almost like a mutual aid type of thing, information. And there's no issue with information sharing?
The thing we don't have is the expert in the field to tell them, the officer that I have that goes out that has a connection with
Spectrum.
Yeah.
Great, and that's, we'd be happy, if you want to try to facilitate, I'd be happy to have a discussion.
And the new people have been great. Anytime that we call, even when other people can't get them, and people taken for, we just have a quick training. It's help themselves. And we have a great staff with probation.
We're lucky in this area. But coming back to Pat, Pat, you mentioned this is not the first time I've heard it. I've heard it many times in casual conversations and at events like this, the number of beds. And I'm going to ask the doctor, and I'm going to ask the treatment providers, what can we do? There was an issue that we were pulled into, and I know Gene was a big advocate a couple of years ago with shutting down some mental health beds here at Clinton Hospital, and we got into, I was told by a lobbyist for the Hospital Association today when I was making some phone calls for an event I'm having next week that I'm not the most popular guy among the hospital administrators. I said, well, that's all right as long as the people know I'm fighting for them. But not to go down that road. But what can we do? What can we do to help the legislators as far as mental health beds are concerned, as far as the quick reaction beds are concerned, working with you guys? You've been nothing but great for our offices when we call, but what can we do? Because it seems to me that it's the beds that are a big problem here.
I would agree with that, and I think that one of the things that has been a real challenge in emergency medicine is the boarding of patients who need acute psychiatric care. And so I think that I'm very happy to hear about the number of treatment beds that are going to be opened in our state, and part of that I think is that there are, as we look at this landscape coming from emergency medicine and then sort of the NAMI perspective as well, it's the entire spectrum of psychiatric illness, whether you're talking about many of the patients that we're seeing in our setting who are there for florid psychosis that may or may not have sort of a drug-induced overlay. We're seeing patients with sort of morbid depression, patients who've had suicide attempts. And so I think that the dedication of opioid treatment beds is essential, and as well as the specialized care that's being made available. And we're very fortunate to have so many community partners that are providing beds in that respect. I think that from a hospital perspective, a lot of what we end up kind of taking on, which is really appropriate, are the incredibly medically complex patients with psychiatric illness. And so when you're talking about patients who are immobile, who have concomitant diabetes, heart disease, like that's where we are really kind of, I see our primary area of focus, knowing that there are so many community specialists who just have incredible traction and experience in this area for patients who, I don't want to say that their problems are any less complex, but maybe they're able to be cared for outside of the hospital setting. And so, we've had incredible experience with the geriatric psychiatric program with Clinton Hospital, and just some of the complexity that I see in caring for octogenarians with psychiatric disease. I think that the hospital's role in this is, we're part of the solution in terms of being sort of the most accessible and cost-effective part of the solution. I see some of our partners who can do these things better than we can, but certainly I think that we're essential. We play an essential role, especially as people become older, more medically complex, and we're seeing so many boomers with addictive disorders that I think a lot of times when we talk about this disease process, we tend to focus on the adolescents, the young adults, the 30 and 40-year-olds, but this is certainly not a disease process that spares people in their 60s, 70s, and 80s. And I again would just say that in terms of sort of the medical complexity of chronic pain, chronic disease, mental illness, I think that we're still fulfilling our role in that particular regard.
David and then Gary.
I'm going to switch and put my old insurance cap on because I can speak to what you're bringing up is a really big issue. I think that, people forget that in the 90s was when Purdue came out with OxyContin, which I think all doctors were well intended when they gave that medication out. And now you're starting to see that population now is now getting older and is now, as you're noting, hitting the geriatric. I think one of the things that, as representatives would be a really great thing to look at is that Medicare has really limited benefits as it relates to substance abuse. So if it's like a person who is Medicare can't get into a residential program unless they're a dual eligible patient, which is Medicaid and Medicare. Why does Medicare not cover that? They recognize it. The government has recognized now substance abuse as an illness. But yet, if a person has diabetes, you can be 80 years old or 40 years old, they're going to treat it. But if you have a substance abuse issue, up to age 65, whenever you become, have Medicare, all of a sudden you can't get treated. And that's what's happening. You have people who are in treatment who all of a sudden will hit 65 and now cannot get access to it. The same thing with methadone. Methadone is a very useful medication for treatment. Medicare doesn't cover it. It seems like simple things that could be easily fixed. Again, even for a detox, if you're not there's different levels of detoxes. So a 4.0, which is the highest level, kind of a medical substance abuse detox facility, there's very few of those in the States. So all of a sudden, if you have a person who requires that level of care, a little bit less, they can't get access to it. So, these are options that are readily available, and yet that population, for some unknown reason, the government has decided to preclude. So in one end, we say there is no stigma. Well, the government has made a stigma because the Medicare population cannot access the services, which is a little ridiculous. So again, if you guys can do something, that just seems like such an easy fix. Make Medicare required as a benefit. All other insurance companies do it. And if you're an insurance replacement product, you can't cover it either because they won't allow it, because Medicare will only cover those services that would be allowed. So a replacement product can't do it either. So again, we're now losing a population that may have had access to treatment, now suddenly do not. So we're actually making the situation worse. So I just wanted to note that.
Derek?
Right. So I love hearing this, and we're on several Mass Health consumer commissions and can take information back, and this makes a whole lot of sense. We're talking about expanding our treatment system, and I heard a very good term earlier, which was making sure that the providers are meeting the needs of the Commonwealth. So that has a lot to do with making sure we have beds for patients that have complex needs, have, quote, dual diagnosis. I think we also have to look at another elephant in the room, and that's that fatal overdose rates have declined slightly among the Commonwealth as a whole due to great work by first responders, law enforcement, Narcan being out there. But if we look at communities of color, they're still shooting up. So making sure that every resident of the Commonwealth is able to access treatment that they feel comfortable in, that they can take part in, is incredibly important, and making sure that that treatment is high quality. So, we get the cream of the crop that come out to events like this because they have the resources and they want to be involved in the community, but we need to make sure that our providers are providing evidence-based treatment and that it's up to a certain standard. And part of that has to do with implementing quality measures in our insurance and in Mass Health, and right now they just don't exist. So that's a pet project of mine, and I'm on a coalition, and so I'd love to talk to anybody about it. Thanks.
Yeah, and in response to your request for beds, on Monday, BSAS actually released an RFR for co-occurring enhanced beds, which would be for those dually diagnosed folks, so people coming in with both a mental health disorder and a substance use disorder. So we are looking to expand specifically in that market. So hopefully, within the next few months, we'll be able to get boots on the ground and open up those beds. So BSAS has responded to a very specialized population.
How are those set up geographically?
It will review the bids as they come in, and we'll take a look from there.
Yeah, that's another important aspect.
I wanted to say that this is somewhat off topic, but I have, just like I take interns in, I have an intern here tonight from Vicksburg State to help me so that I can train to do this unique kind of unconventional work. I have a lot of patients who do really well. They're sober, they've been involved, they love going to events like this, but I would love to be able to say, let's get you on a recovery coach track. And for clinicians that work in this field who have really good patients who are very motivated, there's got to be a way that I can tap into something, do some training with them myself, some kind of way that makes it doable after they certainly, meet the requirements of being eligible. That would be really cool if I could if clinicians and Sarah could do that.
I want Denise to talk about the whole philosophy behind Recovery Coach, because that fascinates me, but I'm also keeping an eye on the clock, and I know there's something going on a little bit after 8 o'clock. Are there any questions from the audience before we delve back into our providers here? I don't want to forget that. Are we good? All right. Absolutely.
So just in terms of the beds, I always kind of like my little pet peeve is, or something I enjoy doing is educating people about the levels of care, right? So detox is the first, step into treatment, and that's just a medical process where you're detoxing your body from the alcohol and drugs. The next level of care is CSS, and that's kind of residential treatment. That's the next, phase of your treatment. That's where the therapy kicks in and that sort of thing. So my pet peeve is that, educating people on, detox versus CSS and, phase 1 versus phase 2, and then what comes after that. So I see a lot of people, going into detox beds and there's not CSS beds available for them. Now they've been detoxed, they go back out into an unsafe living environment, they use again, and that's when a lot of these overdoses are happening. So my big ask, and I think a lot of people are like, oh, we need more beds and we need more beds, and I completely agree, we need more beds. We need more CSS beds. We need to be specific in that, and that's just kind of my 2 cents.
Can you be quick?
Yeah, I just want
Okay.
to mention that the reason CSS is the bottleneck is because people are staying there longer than is designed. So we need to look at the whole back end of the system, I think, not just CSS.
Okay. So, design some enforcement mechanism there. The whole recovery coach.
And Rep, I just want to address, the issue of beds as well. And I want to help clarify that we talk about beds. It's not beds we need. Nobody is running out calling 1-800-JORDAN Furniture, right? We need the workforce that can staff, and so that we can open up and have more capacity to serve people. And that workforce is nurses, we need more physicians, we need to pay the people that are doing this most vital work a living wage. And so when you hear those kind of discussions, if you would equate that to our ability to develop that workforce is going to meet the needs of our communities, I think that would be really helpful. And I think your point about, for the people who are listening at home, as we use all these acronyms, we're talking CSS and we're talking TSS, and that gets really very confusing. What we all need to know is there is a continuum of care. We worry that there's a backup in the emergency room. The backup in the emergency room is actually gridlocked through the whole system. And we have to look at where people are getting services and how we can help them move more fluidly back and forth as their needs are there. But everything we do should be with the thought of the community in mind and the families and the individuals who are really struggling, so we can meet them where they are with what they need in the time that they need it.
Okay. Any other questions among the panelists for each other? Any questions from the audience? Well, I think this worked out well. We rolled with it. Before I'm going to wrap up with one last question before I give some thanks, and that's to who I consider the lady of the hour to come out here all this way, the architect of the current scheme, the current legislation that's trying to provide and for people in this situation and make their lives better, and that's my great colleague, Representative Denise Garlick. And Denise, if you could probably go for 2 hours, but what's next? What should we be doing next when we start the new session in January at the House of Representatives?
So in Massachusetts, what we have done, the opioid bill of 2018 builds on the work of 16 and 14 and 12, right? We identified the issue, we found our data, we know where our resources are, our agencies are working together. This bill puts us clearly focused on the community. I do believe that our next piece of work is around the workforce and how we develop that strength there. But I just want to say to Rep. Naughton, to everyone sitting on the stage, to the people in the audience and the people listening, the most important work we will do is the work we do together as communities on prevention. We are in the middle of a crisis. This is not the new state for Massachusetts. This is something we are working to get through. There is hope, there is recovery, and we're going to find our pathway there for everyone.
Thank you, Denise. Well, if what we did tonight saves one life, it was worth it, absolutely. I want to thank the panelists. I want to thank you, even the panelists who didn't know they were going to be panelists, for rolling with us, for letting us rearrange the format here tonight. I want to thank Principal Jim Hastings at the Clinton High School and Superintendent Steve Meyer, Superintendent of the Clinton School Department. They do a great job in this school. I'm a proud Gale, proud graduate of Clinton High School. They do a great job for our children in the community, and we can be very proud of what they do. I want to thank my staff director, Sue Templeton, my operations director, constituent services director, Steve Mendoza, my communications director, Charlie White, and my operations director, who really took the lead on this, and I really like a great round of applause for Craig Cook for all he did. Everybody here got to know him as we were putting this together, and I'm sad to say we're losing Craig. He was scooped away from me, got a great opportunity. I'll let him tell you. He's leaving us in about a month's time. We're really going to miss him, but he's got the opportunity actually to take a position in China. So he's going to do great work there. And for everyone that came here today, thank you very much for taking time out of your schedules. And I know, we've got, everybody should be home in time, except probably the rep and some. And thank all the members of this panel. This will be going out on local TV. We'll put it out on Facebook Live. And you did some great work tonight. And if I keep the conversations going among each of you, if you don't have each other's contact information, we'll get it. But I've heard several ideas that can be shared and make people's lives better. Thanks so much for coming out this evening. Congratulations to you all as well.